So today we have with us here NK Ganguly, who's the former ICMR director. Thank you, sir, so much for joining us and taking out the time. Sir, mostly our questions will revolve around healthcare. So I want to start with, as India is struggling with a deadly pandemic, a massive shortage of essential drugs and medical supplies added to the health crisis. There was a time when oxygen was not available to people and people were gasping for breath. Then we ran out of essential drugs. We did not even have enough testing kits and other supplies. All of this led to thousands of avoidable deaths. Now, do you think we could have planned better on the availability of drugs in India?
Actually, nobody could gauge the dimension of this pandemic. In my whole lifetime, I have never seen it. Some people had seen the first Spanish flu pandemic, but that was before my age. And some people have seen the plague pandemic and others, but this dimension nobody has ever seen. So nobody could remain prepared. But what Mr. Obama had done, that when H1N1 uh, came up, he asked US to stockpile because there was a lot of deaths in US with H1N1, and he said that future pandemics will come. So do the stockpiling. However, even in US, the stockpiling didn't happen. At least they were not replenished when they expired. They were not replenished. So even US was caught off guard. The UN systems also stockpile, particularly they stockpile vaccines and some medical supplies for the disasters. Like for the pandemic, the cholera pandemic, there is a stockpile for cholera vaccines. Polio, there is a stockpile for polio vaccines. In
Right.
this manner, there was a stockpile for Ebola vaccines.
Hmm.
And, and for wars and for other ravages, they stockpile essential medicines and other things also, which are used. There is a scientific process which is followed for that. Like for pandemic, there are some modeling which is done that this will be the numbers and this could be the future numbers. These could be the vulnerable populations, and the total demand will be approximately 20% or 30% of the total vulnerable population. So looking at that demand, the stockpiling is done. And in the stockpiling, it is not seen as a wastage. It is rather seen as a rescue operation so that you prevent greater losses in the economy and development. So if most of the time, many things which have been stockpiled, they go waste. You have to destroy them or throw them. Many times they are given to some other vulnerable country who needs them, so that also is utilized. So stockpiling should never be taken as a waste. Now the healthcare infrastructure, healthcare system in our country, there was a some kind of a gap over here because our major healthcare money comes from the private sector. Government sector contribution is much lesser. So essentially, the private sector funnels in money, and private sector funnels in money for commercial purposes. It doesn't run charitable organization. Very few run charitable organization, and they put in money. Many of these chains of hospitals are held by international owners. They are not even Indian owners. So in those circumstances, the preparation of the private sector is totally different. And Indian private sector depends largely on medical tourism. From there, they make money. They don't make money from the domestic persons. And most of these private healthcare systems are available in the metros. They are not available in the two-tier cities and three-tier cities. So in our places, two-tier cities and three-tier cities are broken system. Infectious disease requirements are very, very different because you have to see that it doesn't spread too much. to others, and people are kept put in isolation wards, and they don't spread it to others, and they don't spread it to the community. So a lot of these issues are there. So infectious disease hospitals are designed very, very differently. So there are some infectious disease hospitals in our country. There is one in Calcutta, which is the largest. There is one in Delhi. There is one in Chennai. In this way, few of the metros have purely infectious disease hospitals, which we call ID hospitals. However, here it ends. It is not there. There are only single infectious disease hospitals. They are not there in the districts. They are not there in the other cities, which are non-metros. And hence, we have to convert the current medical facilities into infectious disease facilities, which itself
Right.
is a humongous task. It is
Hmm.
not a very easy task to do. And then there are certain so we enhanced beds and we enhanced many things, but but now for the future, now we can really erect a hospital, which army used to do it in the field area,
Right.
in
Yes.
in in a week's time, because it is a screw on technology.
Hmm.
You these are all prefabricated things. You screw them on, and your hospital is made. And then what you need from your stockpiling and others, you put in an appropriate beds, monitors, and other things. So this could be done. This was done, but then it took time, and it didn't have the manpower and the continuous supplies. It was not that we didn't have the supplies. Like
Right.
oxygen supply, we had plenty of oxygen supply.
Exactly. Hmm.
Only problem is that oxygen, that 90% of oxygen used are for the industrial purpose. They are in the steel mills and others. They are very away from our places. Many of them are in Chhattisgarh, some of them are Jharkhand, some of them are in remote places. It takes a lot of time for them to be transported to others. And and in India, liquid oxygen containers were not the norms. They were not being sent to the different places. So they were sent as filled in a steel cylinder. Steel cylinder you can overnight make,
Right.
and hence what was done was aluminum cylinders were fabricated. They can be fabricated very quickly, and they're cheaper and equally good. And we also imported liquid containers as quickly as possible, and then the army and DRDO made liquid containers. It also made liquid containers inside the aeroplane. So liquid containers were transported through aeroplanes. So it was not that there was a shortage. There
Right.
was a problem of supplies and problem of logistic. So,
Right.
so this, and like many of the hospitals have, they use liquid nitrogen. So they have liquid nitrogen manufacturing units in them, where they store tissues, etc., etc. So easily, some of the larger hospitals could have an oxygen making device also. You know
Yes.
that there are oxygen concentrators which can make oxygen through the room air.
Yes.
So So these could have been done, but this kind of a dimension and this kind of a shortage was not visualized. So for future, we need to assess future pandemics, their
Hmm.
size, and be ready, and create a lot of infectious disease hospitals all around. We also have to really strengthen our laboratory services, so that the RT-PCR, which is a very easy method test to do, is done at a remotest point of care. It can be done in villages. India has made such machines which can work in the villages. But then to scale it up in a person and then train people to perform is again something which needed to be done. And at this
Hmm.
given moment, because of the lack of public health laboratory chain within India. This was in medical colleges, this was in research institutes, but these were not in public health laboratories in each
Right.
district or several in each district. So again, we have learned that this need to be there, and we need to see that this is there.
Right. So, sir, just going back to this point that you mentioned, you said that even though India had the supply, we couldn't pass it on to rural areas or other places because we did not have the availability or the access to that. So, I just want to say that several local and remote areas battle and continue to battle with shortages of access to equipment and important drugs required during the pandemic. Now, while strategic stockpiling will help the supply, how can these resources be made available easier to rural India?
Actually, the stockpiling itself will not help. Making inventories will help,
Right.
like Amazon do, like DHS do.
Hmm.
So these are so the inventory making is an art, and procurement to full these inventories from the global market is also an art. India is not able to do it because there are so archaic rules that if you buy, if there is something urgent and you want to buy it within 2 days or 3 days, you are very, very careful. Somebody is going to accuse you of making money or something like that, and you will be in trouble. So that particular part you have to really take care for that particular part, that we should have a world-class procurement system, foolproof procurement system, and an inventory which need to be full. They need to be put on the shelves and
Hmm.
stacked appropriately, computerized, barcoded, so that within minutes you can get them out and load them in the transportation system. The
Right.
second thing, that you need to have a state-of-art transportation system so that you could move to the middle of the Thar desert and deliver something tomorrow.
Right.
And you need to have a supply chain management team which can track a thing, like now you can track your courier things, you can track it has reached here, it has reached there, it is now reaching your home. You can track any good which moves. So
Hmm.
the supply chain man, India didn't have previously courses for supply chain management. Supply chain management is very, very good. It is done best by the private sector. In India, in the government sector, supply chain management is done by the army very well. They can they can put in bridges or infrastructure in the field, or by the Indian Red Cross or the organizations like that. So here, all supply chains are managed by large, big companies. So, so we should have a power to move those things forward, so that they come and they take over, and then they train, and then you create a authority for Indian supply inventories and supply chain management, something like that. Okay, and 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 you we need to produce state of art storage system, because many of the storages might happen at -20, -80, at a different temperature, dust proof, soundproof, free, very nice environment. They have to be put in. So all of these take time to put in.
Right.
The other thing which we need to do is that we need to see that the financing is another architecture. That financing, we need to see that there is an adequate. If there is suboptimal financing, something will give. And third one, which we need to see, that there is an ethics and equity. In India, five goods which are actually subsidized for the uh, poorest 10 quartile or 20 quartile of people, the poorest, they are all used by rich people. Those subsidies are taken by the rich people.
So, sir, as you said, when you're understanding health infrastructure and we are looking at the whole of India, and the whole of India is varied, and sometimes in some parts we're developed, in some we're still so rural that there is no drinking water. So, in this condition, sir, how do we decide that what drugs are essential, and how do we, determine what drugs, equipment, and vaccines should be kept in stock in such places that, when there is a pandemic or when anything happens, we are ready to act and we're not waiting for a week or a month for supplies to come in and for people to act.
Like you see that most drugs which were used during COVID time were repurposed drugs. They were there.
Right.
That technology was there. So they were taken to a quick trial and emergency authorization was given.
Right.
So what happens that like let us take remdesivir.
Hmm.
Just as an example. Remdesivir was an antiviral known. It was repurposed for the COVID. Now COVID suddenly dropped. So Gilead gave license of remdesivir to many Indian companies, 6 or 7 Indian companies.
Hmm.
They started making it. They started making it and they made it also. So there should not have been any shortage. So what happened? Because we didn't have a stockpile, we have the idea of stockpile. This COVID dropped to very low numbers.
Right.
So so this drug was not used. Those who have stocked it started returning to the company. Company stopped manufacturing
Hmm.
because it was not used in any other thing. It was a repurposed drug. So when you start again manufacturing, then it takes time. Factory also has a cycle of manufacturing. It takes time, and then you have to show the stability. Like if it was injectable like remdesivir, you have to show that it is sterile, and the cycle is 3 week, 21 days cycle.
Hmm.
So before that you cannot do. Then you will have to find a method that you can do early clearance of the infectivity, and regulation is becomes very important. And regulations also are very important for availability of drug and other goods, because in the pandemic you use different methods. Like if a drug has been authorized through a very rigorous trial in United States or Europe or any other place, I will start using it. I will not wait to re invent a wheel in my country.